I'm Dr. McFarland from the University of Florida. Some of you I do know, and it's such a pleasure to be here, and I want to thank the organizers from CurePSP, Christoph, Jessica. You guys have been wonderful. The whole group has been wonderful. I've actually been involved with the CurePSP Foundation for many years at our center, and we are a CurePSP Center of Care, have been for a few years now. But I have been treating PSP and atypical Parkinson's disorder for more than a decade now, and it's really been a focus of my work. And I really, I guess you want a geek who really wants to be interested in this disease. It's a tough, a very complicated disease. I mean, for that matter, Parkinson's disease is a very tough disease. It's very complicated, but PSP and other diseases really take this to another level, okay? So you really want somebody who cares, who wants to, to delve into this and to work with a team. And that's what I really have. So as much as I'm going to be talking about this, I have a lot of really great folks at the University of Florida, at the Fixell Institute for Neurological Disorders now, that are part of my team. I can't do this without. So I have a lot to cover here, and my job was to focus on progressive supranuclear palsy, and the other tau disorders. So the other one is Corticobasal Degeneration, and I'm going to revise the name as Corticobasal syndrome, okay? And I'll come back to that to sort of explain it to you. So I don't really have any disclosures for you for this talk, so just put that out there. But I do a lot of clinical trials and work with sponsors. I also have support from NIH and other foundations as well in the past. So these are my goals for you guys today, okay? So you've heard the word Parkinsonism, and I want to talk about just very briefly about what is Parkinsonism, what are these atypical disorders, plus disorders, and how do we get to progressive supranuclear palsy? So a lot of people come to my clinic, they say, I was diagnosed Parkinsonism, but I'm not sure about my diagnosis. Someone said PSP, but I've never heard of this before. It is indeed a rare disease, and there are a lot of other diseases that look like PSP or look like Parkinson's, and this term Parkinson's comes up a lot. So I'm going to go over that, and I'm also going to talk about kind of the understanding the diagnosis, some of the pathological features. Some of it may be detailed, but I don't want to dumb this down for you guys. I want you guys to ask questions. I want to at least show you what we know about these disorders and give you some more information. And then last thing, I'm going to kind of talk to you about some of the therapies that we have available for us. And I know someone's asking about Cure. I realize Cure becomes more of a four-letter word here, but there are bins that we are kind of working on. Cure is one, but certainly if we can sort of find a way to stop this disease either early on or in its tracks, that would be really helpful, okay? All right? But the key is actually identifying you folks early on. You're right, and I kind of hear what you're saying back there. A lot of folks come to me several years into disease, and I'm maybe the fourth, fifth, sixth physician that they have seen who's finally making a diagnosis, okay? So I will talk about sort of treatment options, and I'm going to kind of touch on sort of the advances in therapy that we have out there. It is at the forefront. We have a long way to go, though, okay? But there is some hope, a lot of hope, okay? So Parkinson's syndromes, all right? So that word Parkinsonism, what does it mean? So I have a lot of students in my clinic. The medical students love to talk to me about this, and I use an acronym called TRAP, okay? So T stands for tremor, or resting tremor is really classic for Parkinson's disease. Stiffness or rigidity is the R. Slowed movement we call bradykinesia, and the one end of the spectrum is complete lack of movement. We call it akinesia, so that's the A. So that's where people freeze or frozen or they can't move, okay, when things get really bad. And then lastly, postural instability. So for those of you who know progressive supranuclear palsy, that's a key feature, okay? It's not so simple as just having balance problems. It's that ability to right yourself if you kind of get challenged, your balance gets challenged and you fall backwards, okay? So those are key features. You need to have some of these primary features called either the resting tremor or slowed movement. Slowed movement is really critical, okay? It's a classic feature of all Parkinson's disorder, okay? Slowed movement, okay? So that just sort of gives us a diagnosis of Parkinsonism, which is really more of a descriptive term of a constellation of symptoms. It's not a really etiological term, okay? It's not a name for a diagnosis. So what's most common, all right? A duck is a duck is a duck, okay? So what's most common is Parkinson's disease. There's over 1.25 million people here in the United States alone who suffer from Parkinson's disease. It's the second most common disease, second only to Alzheimer's disease as a degenerative brain disorder. About 10 to 15% of what we see in our clinics, though, as movement specialists, including myself, is not Parkinson's disease, however. Okay, and I'm going to talk more about that. And particularly, I'm going to talk about these atypical disorders briefly. But I'm going to mention down below here on my slide these clinical pathological names and correlates that you may actually hear about. So in the clinic, you might hear your physician, myself included, talk, oh, this guy's got a tau disorder, or this guy's got an alpha-synuclein or a Lewy body disorder. And you might ask, so what the heck does that mean? And why is he using that or she using that term? Well, that's because we have learned in brains from patients who have passed away, okay, that there are these proteins that go rogue. Okay, it's like the brain, there's some sort of spark and the brain catches fire. And these proteins start accumulating and they cause neurodegeneration or brain degeneration, okay? So a lot of them, so Alzheimer's, amyloid and tau, alpha-synuclein you've heard in Parkinson's disease and there are other diseases. There's this term tau, T-A-U, which is found in progressive supranuclear palsy, corticobasal degeneration, frontotemporal disorders. And the bottom you can see there are other proteins. So there is a theme going on here. In a lot of brain disorders that are progressive and degenerative, these abnormal proteins go rogue, they catch fire, and they put the brain on fire, essentially like a forest fire. Okay, so there's commonalities, and if we can tackle one of these, perhaps it may be the key to treating and curing many of the other disorders. We still have a long ways to go. I'm going to point out on this slide, you might see some of these proteins highlighted. Sorry, I don't have a pointer, but on the left, you kind of see here a picture of the brainstem. Those dark areas of the brain are the dopamine cells. They have melanin. That gives your pigment to your skin. And in Parkinson's disease and all Parkinson's disorders, dopamine cells are lost. And that's important in terms of treatment. On the other side, you'll see some pictures of cells. I can't really point at the one on the right-hand side, but there's an inclusion in there. And on the far side, there's a staining of tau, actually what's called a tau inclusion or a neuronal inclusion that's shown in the cells here. It's almost like a cancer within the cell, okay? And you can imagine if these big inclusions or a tumor in the cell will disrupt the cell function, and it's stressful to the cell and causes these cells to die, okay? So, how do I look at Parkinson's disorders, or how do we as neurologists look at them? So when I see Parkinsonism or Parkinson-like symptoms, I think Parkinson's disease first, but it's really important for your physician to think about other things. So we always create lists in our mind and we think about what's called a differential, okay? So there are what we call secondary forms of Parkinson's, so things like stroke or vascular disease, drugs, okay? Infections, inflammatory disorders, toxins, and something called hydrocephalus or called normal pressure hydrocephalus that can mimic symptoms of Parkinson's. So there are a lot of things that we have to keep in our mind. Maybe it's not PSP, maybe it's not Parkinson's disease, so we think about that. There are also hereditary forms. There are a lot of genetic disorders. I'll list one here that's called Huntington's disease, where people have abnormal movements, and they can have Parkinson's symptoms, but it's not Parkinson's disease, okay? So today I'm going to focus mostly on these atypical disorders, and there's several down that I've listed below. The top one is progressive supranuclear palsy, which I'm going to focus on most. The other ones are corticobasal syndrome, multiple system atrophy, and we call it dementia with Lewy bodies, okay? Those are the atypical Parkinson's disorders that are classically listed, and of course what CurePSP focuses on as well. On the right, so I've published this too, so this is the other view from sort of the scientist view, really, understanding these abnormal proteins, okay, or proteins that go rogue. So we can divide these up by synuclein disorders, tau disorders, amyloid, which includes Alzheimer's or AD, and then this other new protein called TDP43, okay, which is more found in frontotemporal dementias and ALS, okay. But we can divide them up actually differently. Why does this matter to you guys? It really matters eventually for that novel treatment, a disease-modifying treatment. We're probably going to focus on these proteins more and more. This is the key, we believe. There's more to it than that, but it is part of the key, I think, to a solution, okay? So it may be important. So what do I do as a clinician? Is it other than Parkinson's disease? I have to ask myself, when I see patients. There are red flags, of course, so I list these. So Parkinson's disease is a slowly progressive disease, all right? We talk 15, 20, 30 years of a disease. So having a rapidly progressive disease is a red flag. Early prominent speech and swallow issues. So Parkinson's patients, when I see them, they have some monotone speech, but they don't within the first 3 or 4 or even 5 years start having swallowing problems or markedly impaired speech problems, okay? So that should be a red flag. Early balance problems, and I'm going to come to this really quickly in the talk actually, but early falls, freezing, postural issues within the first few years should be a red flag to your neurologist, okay? Other atypical features like an odd tremor, if it's not a resting tremor seen at rest, like maybe when you're sitting watching the TV, different kind of tremor. Now tremors do vary, okay? There's lots of kinds I see, but that should be also kind of a track. Another symptoms I'm going to talk about. Levodopa. Levodopa is probably the gold standard therapy in most Parkinson's disorders. So I often get referrals for patients who fail to respond. Now I will say that I would say roughly 20-25% of Parkinson's patients, not every symptom responds to levodopa. So it's not a black and white issue, it's more gray. But the lack of response should be kind of a clue to a physician. There are all these other plus features on the right side that I point out too, okay? Plus features like gaze palsy that we see in PSP. I'll show you some examples, okay? Autonomic symptoms. So the autonomic system is part of your nervous system. It controls things that you don't have a lot of thinking about, like blood pressure, heart rate, bowel and bladder issues, sexual function, sweating, okay? These are all part of we call the automatic nervous system, okay? And these things are actually impaired in a disorder we call multiple system atrophy that you'll hear about later. It can occur in Parkinson's disease as well, but maybe not to the same degree. Early cognitive issues, dementia, behavioral issues, hallucinations, delusions, and other features I list here, like a weird abnormal movement hand. These are what we call plus features, okay? That should also give a clue. It's not Parkinson's, okay? We should do some more investigations, maybe see another specialist. And we always do recommend seeing a movement disorder specialist if you have a complicated disease like this. So, I come back to the duck, all right? So if it walks like a duck, it quacks like a duck, it's usually a duck. So it's usually Parkinson's disease, but this is what I'm going to talk about. Sometimes it's actually not a duck, it's actually the swan or it's a goose, and sometimes it's a swoose, you know, the atypical forms of some atypical diseases. So that's where we come in as specialists. So I said at the beginning, I'm going to focus on the progressive supranuclear palsy and corticobasal, the tau disorders, okay? So if I take you back, there are many other tau disorders I'm listing here, but I'm going to mainly just talk about these two, and I'm going to focus on these first just to give you the idea what are the symptoms. You might recognize these individuals. There are a lot of individuals, famous people that are affected by diseases. Anybody know the guy on the right? Okay, all right, that's good. This group will know. My younger crowd does not. So, but a lot of folks are being affected by the disease, and they're real folks, and we know these folks, okay? The diseases I'm going to talk about today are part of a spectrum of diseases. So talk about Parkinson's disorders. Now I'm going to bring up a whole new topic called frontotemporal lobar disorders, okay? So this is a different kind of dementia. It includes sort of Alzheimer's disease as part of it, but there's a spectrum, and there's a spectrum of brain pathology, and remember those proteins I talked about, tau. Today I'm going to focus on the right of this spectrum of disorders, but you can kind of see there are lots of different diseases that are related to this. But corticobasal degeneration and PSP are part of this 4-hour, and I'm going to talk more about tau later here in terms of pathology, but are part of these disorders. It's on the right-hand side, and these have a lot of movement features, but also cognitive features that are very much under the spectrum we call frontotemporal lobar dementias, okay? Now I'll touch back on that. Okay, because there are many features that are common in these disorders, okay? So first talk about progressive supranuclear palsy, okay? So we've come a long ways. So it's now been over 60 years since this was first described by Richardson, Steele, and Olszewski. I love this because this is a combined effort by a professor, a pathologist, and a resident, a neurological resident. So just think about that. So someone in their training, a scientist and a physician coming together to describe a disease. So the way it is happens. But it's an amazing kind of collaboration. And they first described this disease with earlier, postural issues, gait issues, gaze problems, rigidity, and dementia. We've come a long ways since then, and I have sort of a timeline in history. I will not go through everything here. But since the discovery, there have been a lot of highlights, and I picked just a few for you guys, So since the first description, it didn't take very long for folks to realize pathologically it was associated with the tau protein, so protein accumulations in brain, particularly neurons, as well as those supporting glial cells. And it was present in both PSP and corticobasal degeneration. There's a mouse model that came about in 2000. It's actually more of a frontotemporal lobar mouse model, not a PSP model. So that's something we can discuss. We need better models, okay? In 2010, moving forward, we had our first GWAS, which is a genome-wide search that was published, okay? Now, I will talk more about genetics and whether it plays a role in this disease. You've heard already that it's primarily sporadic. There are a few other things here, some clinical trials that have been out. These are failed trials, but they still were out there. I think this is significant. So, when I first started, there were no trials in this disease, okay? And now there's been an explosion of trials, and there are many more to come. So it's a very exciting time to be in this. I know we don't yet have the cure, but think about this. Just 10 years ago, there were very few trials, if any, in progressive supranuclear palsy. So we've come a long ways. And there are big companies now that are funding clinical trials in this disease, and we want more of them because it does take a lot of effort for a rare disease to do a clinical trial. Okay, so what are some of the clinical features of progressive supranuclear? I'll begin with this because it is one of the most common atypical forms of Parkinson's that I see. We see actually about 100 patients a year in our clinic alone from here in the state of Florida. So the estimated prevalence, it varies depending on the study, anywhere from roughly 2 to 10 out of 100,000 patients. So if you kind of take that, there are million plus Parkinson's patients, there's about 30 to 40,000 in the United States of PSP patients. Average onset's roughly in the mid 60s, okay, 36 or 63 to 67. And for diagnostic criteria, you have to be at least 40 years or older. I've never seen anybody actually in their 40s, but 50s or even earlier, so it's kind of rare to cap that. And then median survival I placed up here. Average is 6 to 10 years, but it depends. There is a long duration form of PSP that we see, and some patients I've had survive 15 to even 19 or more years, although wonder about the type of disease. So what are the classic features of this disease? I've already mentioned some of them. So on the left, I show you just sort of features of disease that are part of classic. So early falls, posture instability, eye movement problems. Supranuclear gaze palsy, and I'll mention more about this, is a higher brain thing that directs where your eyes move. So inability to move the eyes up and particularly down and eventually left and right volitionally is a big part of this disease. Rigidity or stiffness. Remember I said that was a part of Parkinson's? Well, this is a significant part of this disease. Particularly axial or truncal rigidity is a big part of this. Early swallow and speech issues happen in this disease within the first few years. And then behavioral and cognitive issues. This again falls under this umbrella we call frontotemporal lobar dementias. So there is a dementia. Sometimes it occurs earlier, but often it occurs later. And it can be hard to really pick up because as patients progress, their communication can become limited. And it's hard to assess cognition sometimes. But there is a progressive dementia in this disease. And there are many other features. That classic facial stare. You've heard of the lack of facial expression in Parkinson's. In this case, there's a stare because the eye movements are lack. Difficulty looking down at their food, sloppy eating, sleep issues, bowel bladder problems. There are mood issues that range from anxiety to depression to labile mood and what's called pseudobulbar affect, which is inappropriate laughter or crying. Okay. So a lot of things. I'm going to highlight on the right here in my slide the early falls. So if you look at the graph here, so it shows us months on the bottom, and then you see different diseases. PSP is up on the top. But for Parkinson's disease, falls typically don't occur within the first 5 years. Okay? They start occurring 5 years or later frequently. So compared to other, like multiple system atrophy, which is MSA, vascular disease or vascular Parkinson's, PSP falls often occur within the first few years, and there usually are falls for no apparent reason initially. I fall. Typically, I fall backwards rather than forward. Usually my Parkinson's patients fall forward because their center of gravity is forward and they're shuffling forward and rushing. That's not the same thing for progressive supranuclear palsy, okay? So gait is kind of complicated in this disease. It becomes reckless, and because of the cognitive issues, maybe impulsive behavior, people get up, forget their walker. I don't know if anyone's done that before. Leave their walker or their wheelchair behind, and they get up without some assistance, and down they go. Okay, and I've seen some very spectacular falls with this disease, with major injuries. So it is a big comorbidity for this disease. Eye movement. So I'm going to take some time to talk about the eye movement abnormalities. So they're very complicated, and they range from just non-specific eye complaints, blurred vision, just my eyes hurt, they're red, I have trouble reading, I have some intermittent double vision sometimes. Some patients actually present with difficulty opening their eyes, and some people have spasms where their eyes close, causing essentially functional blindness. Okay, their eyes are closed all the time. If it's a spasm, we call it blepharospasm. But one particular thing about this disease, progressively, some people have just the program, the computer, the brain program that tells you how to open your eyes becomes dysfunctional. We call that an apraxia. Okay? It's a problem with a learned function in opening your eyes. Believe it or not, it's a learned function. So patients have to pry their eyes open to see. Okay, so it's a big issue. The main clinical thing is this supranuclear gaze palsy, and I'm showing on the right hand, unfortunately the slide's not showing it again, but the eye movements become abnormal. Up gaze, as we get older, becomes limited, so it's not a very specific thing. So we focus more on the speed of down gaze and limited down gaze. You can imagine what that affects. So if you can't look down, you can't see what you're eating. If you're walking down steps, you can't see the steps and you trip and fall. Okay, you can't see what you're walking over as well. So down gaze becomes progressively impaired, and that's really the most sensitive feature on my exam to identify patients with PSP. Eventually, horizontal gaze becomes impaired as well, and that leads to basically that stare in gaze that you can get. I wrote Mona Lisa stare, if you've ever seen the picture for Mona Lisa. There are other issues that happen. Sometimes there's impaired, looking to the left or right. There's abnormal movements we see, the eyes jerk when they fixate. And I mentioned sort of the square wave jerks, but that's something that us physicians will be looking for. All right, so how do we make this diagnosis now? Okay, so there has been some evolution. There are initial criteria published, and most recently, the Movement Disorder Society published in 2017 some new diagnostic criteria. So as a physician, this primarily remains a clinical diagnosis, and we use clinical criteria. So how do we diagnose this? There are 4 pillars of clinical features that I look at, or as other neurologists should be looking at that. Ocular motor or eye movement issues, okay, looking for that vertical supranuclear gaze issue, looking downward typically, or just slowing, okay? Postural issues, gait problems, the balance issues, okay? If you present within the first few years with early falls for no apparent reason, particularly backwards, okay, that is a #1 kind of criteria. The other pillar is lack of movement, or that we call akinesia, or just slow movement, and I show you a number of those on the list here, and then cognitive issues, okay? So I'm going to go through these a little bit. There's a tiered approach to this. So patients who present with just obvious eye movement problems, falling early on, that's PSP, okay? Now most of these patients have rigidity or stiffness, and they're not really very responsive to levodopa, okay? And that's a common feature. Another common feature is the C2 sort of frontal issues. So what are those frontal or cognitive issues that are common? So some of the common issues are slowed thinking, executive problems, that's organizing, doing basic tasks, multitasking, okay? Slowed speech as well, coming up with words. Those are common features. Now, you can see there are variations here, okay, and I'm going to point that out briefly here. Some patients, this A1 under akinesia, present with freezing, okay? So when they stand up and they start walking, they get stuck like this, and they can't move at all, or one of their feet. That's called freezing of gait. And some patients present with that as a primary feature, but not all. Classic PSP doesn't usually have that, okay? Usually the gait is just very unstable, okay, with falls backwards. Some patients also present with more of a Parkinson's overlap. They sometimes have tremor. Tremor actually turns out in classic PSP is not all that common. So some patients present with early what looks like Parkinson's disease with a classic rest tremor, and then they gradually progress to have more eye movement and a lot more balance problems. And we call that PSP parkinsonism. Some people present with a lot of early speech and language problems, okay? With effortful speech, trying to find the words, becoming agrammatical, really searching for words. And that's what we call this non-fluent, this top C1. And then there's this thing called corticobasal. So I'm trying to hint here is that this is not just one disease now. We have recognized in the new clinical criteria take into account that this is a heterogeneous disease. So this makes it much more complicated. And I realize you're thinking, okay, PSP, I've heard it, that's enough. So now you're going to make it more complicated? Yes, it is more complicated, but we can identify some of these variations. And there are other supportive features I list down below here for us clinicians that we see. The levodopa resistance. Some patients present with a lot of photosensitive and they wear sunglasses inside when I see them, and then imaging things. And I'm going to come through all that. But what I'm trying to get at is we have learned that this is a heterogeneous disease. In fact, a large pathological study looking at all kinds of, like over 100 PSP patients demonstrated that there were all different, we call phenotypes and way this presents. So not one patient is the same. Just like with Parkinson's, you see one Parkinson's patient, you see one Parkinson's, you're all different and unique, okay, in your own way. But we can put you into some bins, and now there are some different names. Some patients present with predominantly eye movement problems, and they develop the gait problems later. We call that an oculomotor presence. Some patients present with predominantly the gait problems and no eye movement issues, and that's sort of a hint towards it, but they develop that later on. There are patients who present with a lot of we call cognitive issues, predominantly language issues, sometimes behavioral issues, okay, like frontotemporal dementia, where they're disinhibited, they act out, they have behavioral problems, they get angry easily or irritable, okay, and they're very impulsive, okay. So that we call a frontal predominant, okay, and there is a overlap with corticobasal, and I'll come to that in a little second here. So now we have some diagnostic criteria. There are levels that we have. Some patients is just suggestive, some patients are possible, probable. Still, a definitive 100% diagnosis today really relies on brain pathology, unfortunately. And I'll come back to that because we need better markers of disease. Okay, and I'll come back to those biomarkers like blood tests and other tests, okay, and imaging. So this is kind of the way we look at the disease. There is actually a clinical progression. Some of these types of disease all progress to what's called classic PSP, and the name we use for that is Richardson syndrome, heralding back to the original publication and description of this disease, okay? There's a lot more going on here, okay? There's a lot of overlap. So this is where a specialty, a movement disorder specialist is really important. A lot of these disorders overlap with features of Parkinson's, AD, what's called Alzheimer's disease, dementia, frontotemporal dementia. There are a bunch of other things we're going to talk about multiple system atrophy, and there are going to be some overlapping features, okay? And some patients have features of both. On the right, I'm going to talk about, I just want to mention mimics. I mentioned normal pressure hydrocephalus or fluid on the brain. This can look just like this disease in a lot of ways, but it can be identified on brain imaging and with classic tests and a good clinician. There are immune causes that mimic this, and there are even infectious causes that potentially mimic this disease, okay? So you have to look at it. So people do ask me, do I really have PSP? Yes, we can diagnose it with really good confidence, but it's important to think about other potential causes. So I'm going to talk about the step cousin, okay? So corticobasal syndrome is a related disorder, and I don't call it degeneration, and I'll tell you why, okay? But this disease is basically the cousin of progressive supranuclear palsy. It has similar but different features, okay? So number one, it has a combination of cortical issues and behavioral symptoms as well as Parkinson's features, okay? It's much less common, about 10 times less common as progressive supranuclear palsy. So it's a rare disease. So by comparison, we see probably about 20 to 30 patients a year in our clinic. Mean onset is similar to PSP. Progression and overall prognosis is about the same. And there are many different presentations, just like with PSP. So the classic form of this disease often has what's called corticobasal degeneration, but there are other presentations that look like PSP sometimes, Present with a lot of language issues. Language issues, when you have problems speaking or language, not the mechanical part, we call that an aphasia, okay? It's a brain issue, okay? And then behavioral problems. And you'll probably see on the bottom here that I also point out that there are different brain pathologies as well, okay? So it's not just one brain pathology. So let's talk about classic corticobasal symptoms, okay? So I mentioned there are two types. There's the Parkinson's involving motor symptoms, and then there are cortical signs. So on the left, I list some of those Parkinson's features. So a lot of times patients present with a really asymmetric stiffness, rigidity. They may have abnormal posturing. We call that dystonia. That's kind of pulling or posturing of the hand or the leg that can occur. The tremor, it's very atypical. So we don't see that often in PSP. In this particular case, it's a coarse rest or even an action tremor, okay? It's a different kind of tremor, okay? Patients can have spasticity, not just rigidity, so a little bit different form of increased tone. Gait difficulty occurs usually later in disease. There can also be speech, swallow language, and even gaze impairment disease, just like progressive supranuclear palsy. But the key feature often is that asymmetry to the presentation early on. The cortical signs. So I want to focus on these. These are kind of the differentiating features. There is a dementia. Language deficits. Remember, language deficits are a brain issue, a part of dementia. Abnormal movements we call alien limb movements, okay? I don't just mean limb raising, but a limb like a leg or an arm doing something that the patient often recognizes as not being their own, or they seem to be confused. This limb is doing this. It's reaching over and interfering with my activities, or it's just doing this weird thing on the right-hand side when they're doing it. They don't even notice it. But oftentimes the key feature is that patients say, I'm not doing that on purpose. That's just doing it on its own. I have no control over it, okay? So other things that people can see are sensory loss. It's usually a sensation loss. It's not I'm numb. It's difficulty identifying things in your hand, or if you write something in the hand, they can't detect that. So these are signs that your neurologist will look for. And sometimes people have abnormal jerky movements too. Okay, these are all cortical signs and features. So what are key features here? Okay, the big key feature that I take, and a pearl I take home really is, as opposed to my Parkinson's patients, most of these patients present to me saying, my arm or leg doesn't work. Okay, they don't say it, I have tremor, I have coordination problems. They say, I can't use my arm or my leg. I try to make it do stuff, but it just won't do what I want. That's what we call an apraxia, or a problem with a learned behavior, okay? Abnormal posturing, jerky movements, and then later gait imbalance. So these are key features that we see in this disease. And it's often universally poorly responsive to medications, unfortunately. All right, so describe the different diseases. I want to step back and talk about some of the brain pathology. Again, I'm going to talk about tau pathology mostly. So, all right, I'm going to bring you back to this spectrum thing, and I'm going to show you a really complicated slide. But in the bottom here, I want you to look at the 4R tauopathies, and I'm going to talk to you about what does 4R mean. And you can see they're all kind of red, but you can see there are different disorders here. And there's a spectrum of brain pathologies, including different proteins. At the bottom, there's tau, there's TDP43, there's another protein called FUS. So there are different proteins that are involved, and they're mixed brain pathologies. So it gets really complicated quickly. I'm not going to focus on that. I am going to focus on tau for you guys. So what is tau? And what is this role in disease? Okay. So I'm going to come back again, just tell you, this is a normal protein, just like amyloid, okay? All right. Its main function is to stabilize microtubules. So microtubules are a structural protein in the brain, these nerve axons. It's there. You know, axons are long. They go a long ways. Sometimes they go from the spine all the way down to your toe. Okay, but the brain, they're shorter. But needless to say, they're structural proteins. They need to have a scaffold to it, and tau actually binds to it normally. So phosphorylation, it's a phosphate binds to this protein. It's a normal protein, a normal thing that happens to many proteins. But tau, when it becomes hyperphosphorylated, starts to disassemble from the microtubule, okay? And it starts to aggregate, okay? Both in the nerves as well as the supporting cells. When that happens, you have a loss of structure. And it also causes a cascade of other events. So again, this is that brain catching fire. So what is the spark? It's probably this hyperphosphorylation, and it leads to this spreading fire, spreading forest fire in your brain, okay? All right, and it leads to these tangles, plaques, and you show this is a neuron here, and there's a brown thing in there that's a stained slide, okay? So the brown thing represents a tau aggregate. And you can see it fills almost most of the cell, okay? That's a big issue, okay? And it causes that cell to eventually die and leads to neurodegeneration shown here, okay? So tau is a protein. It's made up of a lot of different components. And I show you it up on the top of this slide. And it turns out that, when you have lots of Lego components, you can put together a Lego piece with different parts, okay? So tau, just like with Lego parts, you can reassemble it in different forms. And it turns out in the brain, we have different isoforms of tau. In fact, you can make 6 different isoforms depending on when you include these parts or not. Tau actually has a repeat domain. There's a 4 and a 3R repeat domain. So we talk about different types of tau in the brain. PSP, cortical basal degeneration, have the 4R or 4 repeat type of tau. All right, that's as complicated as I may get to you. All right, but suffice to say, there are different disorders that are related to these different forms of tau, and it becomes important for us scientists in targeting the right thing, okay, for treatment in the future. So I'll list some of those down there. So what happens? So brain pathology in PSP, the classic pathology is actually more than, not really neuronal, it's glial. So one of the supporting cells, actually the astrocyte, which supports your brain cells, develops tau pathology. And the classic one is this tufted astrocyte that our neuropathologists see on pathology. It leads to basically degeneration of the brain. And I show you pictures of the brain on the right side. There are areas of the brain that degenerate. I wish I could point here. But I'm going to have you focus on the bottom slide here. One area of the brain that degenerates in PSP is the brain stem, and we often focus on the midbrain. Okay, that's the top part of that. So look at PSP on the bottom here. All right, I'm going to point you over there or over here on that slide. Okay, and when you look at it from the side like this on a brain scan, we often see what looks like a picture of a hummingbird. Okay, so you can see the beak appearance of the midbrain there. The belly of the hummingbird, don't see the wings, but basically this is what we look for, okay? And in fact, there are measurements of this, and I'll talk more about that a little bit later, that we use to help support the diagnosis of PSP. We now recognize there are multiple pathologies, so this is a nice publication earlier in this decade. So just showing that the different forms of PSP have less or more widespread tau pathology. Richardson syndrome is in the bottom right. Unfortunately, the classic form of PSP shows probably the most widespread pathology. If you want to think about it as that forest fire, the forest fire is really hot in classic progressive supranuclear palsy, and explains why this disease rapidly progresses. Okay? In corticobasal syndrome, it has the same type of brain pathology, a tau. It's a little bit different. Okay? And it turns out that there are multiple pathologies. So only about 40% of the cases are classic cortical basal degeneration with tau pathology. So sometimes this is Alzheimer's pathology, sometimes it's other causes as well, okay? So it's mixed, okay? But the classic form is tau. We still use that 4R type of tau. It's a little bit different pathologically, often looks more spread out. We get these diffuse plaques. Now you may hear plaques as part of Alzheimer's. These are different kinds of plaques. These are not amyloid plaques, these are tau astrocytic plaques, so different. So some of you may have heard that term, plaques and tangles, okay? With brain scans, okay, remember this is both a Parkinson's, we have motor features and cortical features. So sometimes we look at the cortex, the higher part of the brain, and we can actually see signs of atrophy or shrinkage. And there's a scan here on the bottom here showing atrophy, okay? All right, again, I'm going to point to it a little bit here, shown on the right. You can see there's a little bit of an asymmetry from left to right, and that may represent the symptoms and the asymmetry that we see in this disorder. Okay. So I'm going to step back and just talk about some of the findings that we have, some of the science that we know. I think you've heard this is primarily a sporadic disease, but we have explored some of the genetics of PSP. Okay, and there's some things we have learned. So tau is actually encoded by the gene called MAPT, okay? And it's associated with a form of frontotemporal lobar dementia, but it's rarely mutated in PSP. So that's strange, okay? They're extreme. I can count on one hand that there are families in which you find PSP. So the vast majority, I mean 95+% of this disease is sporadic and not associated with a known genetic defect that we're aware of, okay? So screening for genes have low yield in PSP, even if you have a family history. Although if there's a strong family history, we would actually do that, okay? There is some association which was called a blood haplotype called the H1 haplotype. So patients either have H1 or H2. If you have H1 haplotype, that increases your risk for the disease, okay? Most recently, we have had this publication of a G9-wide association study, and several other genes have been identified that may play a role in the disease, okay? And I'll show kind of a little bit of the data shown on the bottom here, okay? But we still know little about these genes and how they play a role in PSP, okay? So it's a complicated disease. I will tell you that genetic diseases, you know, sometimes are causative. Other genes are just we call risk genes that increase your risk, but they may not play a role in the exact cause of your disease, okay? Hope that makes sense. And we can, if you guys have questions about it, I'm happy to answer about that. So lastly, I want to turn my talk to treatments, the diagnostics that we have and frontiers, okay, the future, okay? So what do we know about these treatments, okay? So to help me diagnose this, I've shown you some pictures, I'm going to come to that. I think everyone wants to ask, is there some test I can have just to tell me I got PSP? How come you're not sure that I've got it? Why is there doubt always? Well, the problem is there's no reliable blood or spinal fluid markers so far, okay? So I want to repeat that. There's no reliable blood markers so far that's been found. So we have looked at spinal fluid, so we have to do a spinal tap to get it, and increasingly there are some data showing when we look, we can measure proteins like tau and amyloid, and we can look at the different forms, and there's some increasing information that this might be helpful. It seems to be more helpful for Alzheimer's than it is to PSP. So Alzheimer's patients do have alterations. PSP patients don't have low levels. There are other ways to detect proteins. So there's amplification methods. And on the right, I show you some increasing data looking for tau. There's definitely progress in Parkinson's disease for alpha-synuclein. Tau has been really tricky. I'm going to point you back to that slide where we had 6 different isoforms of tau. That makes it much more complicated. We don't have the same thing for synuclein. A little bit more straightforward. So it's difficult to amplify this, but we're looking for proteins in your blood, not necessarily in the brain, and representing that. It's hard to kind of amplify them. But you can kind of amplify them in a test tube, and we're beginning to get some techniques to detect things. So this is an area of research I want you guys just to stay tuned for, because we do need a test, okay? Neurofilament is actually a marker. So you may hear about this one. It's a marker of brain degeneration. It's not specific. So most brain degeneration disorders they leak this protein out of cells, and you can detect it in fluid, okay? It is higher, and in diseases like progressive supranuclear that are more rapidly progressive, it rises, okay? It's something that we can measure, but it's not specific. So the question is that very helpful to us? So we're still looking again. But I wanted to give you kind of a clue. I showed you the hummingbird, okay? There are other measurements that scientists have been using to detect PSP, and some of these brain measurements can be very sensitive, up to almost 95% in terms of differentiating a normal person from Parkinson's or even progressive supranuclear palsy. So there is some advances. At the University of Florida, we're using what's called a diffusion technique, and we're using automated measures nowadays, and we believe that we can detect early changes in progressive supranuclear palsy, multiple system atrophy compared to Parkinson's disease. And that may be a new test that may be used, or a new biomarker. So images can also be biomarkers for disease. You may wonder about PET scans. You've probably heard about PET scans. PET scans are largely research-based. Most centers have what are called metabolic PET scans used to detect cancers, but we can use different brain tracers to look at brain disorders in PET scans now, and it's becoming more widely available. We, at the University of Florida, our Fixel Institute recently just installed a PET scanner as well, and we hope to look at different ligand. So you've probably heard that Alzheimer's disease now, we are beginning to approve what are called PET scans for amyloid, so we can detect amyloid burden in Alzheimer's. So in PSP and cortical basal syndrome, we want to detect tau burden. So tau's been difficult, but there are increasingly pharmaceutical companies out there, and they're even in Florida, that are developing tracers that can help detect these tau accumulation in the brain. And I just want to give you some pictures. These are actually colorized pictures showing you that we can detect sort of brain and PSP, their brain changes, they highlight, they show that forest fire in the brain, okay? So they begin to detect, so one of these tracers called fluorotau's appear. It can even show some of the cortical issues shown on the right in corticobasal degeneration. And for some of the different forms of PSP, we can even look at both the brainstem and the cortex, okay, of the higher brain to detect sort of the speech language issues. So on the right, you see that red circle pointing at an area of the brain on the left side of the brain that's hot, okay, that takes up this brain tracer. So PET scans are coming your way. They still are largely research, but I'm hoping soon these will become clinical once these tracers are more validated in the future. And the key here is diagnosis. Our goal is to have early diagnosis and detection, okay? So I'm going to turn to treatment briefly here. The focus wasn't on treatment, but I want to talk about it. It's really complicated. This is the way I look at it. You guys are the patients and family. You're the center. In our clinic, we think of you the sun, and that we want to bring our care to surround you. There's an inner core group of people who see you. That's me, the nurses, our therapist, our case manager, who's our social worker, psychiatrist, you name it. And there are all these other people that are part of your care group. It really takes a village to treat these disorders, okay? One person is not usually enough. I'm not enough, okay? These are complex diseases. I'll touch on treatments briefly. Complicated slide. Treatment is difficult, okay? We need better treatments. Unfortunately, as a rare disease, it's been tough to study. It's hard to get enough patients. That's what CurePSP and other organizations are out there to help put the people together. For the Parkinson's, we always try to treat patients with levodopa, and we try to give patients a decent dose. That means up to roughly 300 milligrams 3 times or 4 times a day, okay? So I get patients who come in who've only tried maybe 1 pill 3 times a day. It's not an adequate trial, okay? Now, there may be problems with tolerating the drug, and that may limit going up to a higher dose, but it's worth trying. There are a lot of other Parkinson's agents. They've all been looked at in limited studies, and they're all inferior to levodopa, unfortunately. So I wish we had better things to treat the Parkinson's with. We just did a study on amantadine, which is an old Parkinson's drug. There are no randomized trials, okay? That's the gold standard in research trials. It universally fails to treat this disease, although there are a few patients who do respond, so it's worth trying. I know people are desperate for anything. We're willing to go on a limb sometimes and try medications, especially if the side effects are only temporary, and usually when we stop a medication, the side effects go away. So it may be worth trying other medications, so always keeping your mind open. For the dystonia or the abnormal movements, we use muscle relaxants. Botox can be really helpful for focal limb dystonia. For dementia, unfortunately, there really aren't any good drugs for the dementia. We do have dementia drugs that treat Alzheimer's, like like donepezil, rivastigmine, but typically in these diseases, this is not Alzheimer's disease. The pathology is different. Patients fail to benefit, and sometimes they have side effects. So I don't usually recommend these medications for patients. I always treat mood issues. This is a difficult disease and coping, and patients do develop labile mood sometimes, or even what's called pseudobulbar affect, that inappropriate laughter and crying. And using antidepressants can help. There is a medicine called what's called dextromethorphan and quinidine, or called Nuedexta, that can help with the pseudobulbar crying as well. But it does have side effects and can be expensive. There are other issues, systemic issues, the sleep issues, the urinary bowel issues, and we try to treat those as well. So it becomes quite complex. And I list some other medications listed here, and I'm happy to answer questions individually with you guys as well about that. But I just wanted to list treatment. Again, I'm going to highlight this. It takes a village. I really rely on our rehab folks. We have a great person here already today that talked to you yesterday. Medications only go so far. So we need to have physical, occupational, speech, our nursing and our social work, our social services to come together to help patients. So falls are a big deal. Okay, patients need to use walkers early on. There are different kinds of walkers. Occupational therapy treats daily activities. So making it easier for you those daily things like dressing, grooming, using the bathroom. Okay, speech pathologists. always talk about early speech issues. If communications become a problem, ask your speech pathologist to talk to you about alternative ways to talk, like a word board or even a tablet, okay? Communication among loved ones is key, and it can fade, okay? Nursing coordination, we work with home, and then social services are key to help provide things. I will mention palliative care, it comes up a lot. I'm going to use the term palliative. It's a big thing, and I often bring it up early on because this is a progressive disease. And we even talk about this in Parkinson's disease. And it includes hospice, but it's not just hospice. Palliative means comfort. So in diseases like this, we need to have a discussion about quality of life versus quantity of life. And often quality matters more than quantity, okay? So what is palliative care? Focusing on your comfort, and sometimes rushing to the hospital all the time is not what we want, okay? Having those doctors stick lines and you put something down your throat, try to keeping you alive is not what we want. We want to be home with our loved ones, okay? So having care on your own terms, and you need to tell your loved ones what you want, especially in a disease where communication can be difficult. Emotional well-being, spirituality, ending your life in your own terms. So talk about this. I know it's uncomfortable, but don't let your physician not talk about it. Bring it up if you have questions about it. It's a scary disease, and I agree with you all. But this is something you need to spend a few minutes to talk about. What's not, there are lots of different hospice companies. Often you don't have to give up your doctor. I can still be part of the team. I know some hospice companies do take over everything. We can usually continue medications. Levodopa is important for comfort if it helps you, okay? So we don't have to stop those. So talk to your physicians about this, challenge them. Bring it up early, okay? Rather than later. Don't wait. Hospice can start earlier in patients who need it. Sometimes we have patients in hospice for 2 years, okay? And they can be really important. So lastly, I'll just talk about emerging therapies. I don't think Christophe didn't have time to talk about all these. But I want to highlight there's been a lot of progress in PSP. So this is just a list of trials, and they've been going on for over a decade now. Lots of different drugs like Riluzole, tried for ALS, it works a little bit, but doesn't really work in PSP. Supplements like CoQ10, I still use them. It's well tolerated. There are only 2 studies in PSP that showed a borderline effect, but it's really well tolerated. Why not take that? Stem cells, there are only a few groups. There's a group in Italy that's doing some of this, yet to really show any benefit, okay? I don't recommend people run out to companies who are offering stem cells. They want your money, and they're willing. There are lots of companies all around the country that are willing to take your money. It's thousands of dollars. There are risks to getting stem cells, okay? And the people who run these companies often, they'll tell you that they can cure everything under the kitchen sink, including PSP. But at the moment, it's not true. There is hope for stem cells, okay? But you should, at least my recommendation, this is just my personal opinion, you should be part of a clinical trial. And usually trials compensate you, not the other way around, having you pay to be part of a trial. And these are people doing trials on you, because this is not an approved therapy for these diseases, okay? All right, so just be careful, talk to your physicians. We'll try to keep you safe. There are a lot of different studies that are things that are targeting tau. So tau is a big target, and I list a bunch of them down here. All of these have so far failed, although the Rho kinase inhibitors are a new one on the front, and we may hear more about those. I'll just list immunotherapies. So the tau protein's on the top. This is the way us neurologists and scientists kind of put a schema up there. We take the protein and we unravel it like in a string, and there's a N-terminal, there's a C-terminal, there's different parts to it. Antibody therapies are out there, they've been tried. There are lots of different antibodies now targeting different parts of the protein. 2 have failed at least, or a number of these have failed. Some of these antibodies are active immunotherapies like vaccines. So you've heard about vaccines for different diseases. There are vaccines coming out as well. And some of these may come out in trials in the future. So we may hear more about these, but I just wanted to see, this is a busy, busy slide. There's a lot of work going on, okay? Lastly, I'm going to throw some science at you, just in case anybody sticks in here. So proteins, so I showed you a line of this protein. Proteins are formed by amino acids, and then they fold, okay? They form configurations. And tau is one of those proteins that does the same thing. we're discovering, this is a totally hot off the press kind of different discovery, that there are different forms of how the protein folds. It's the same protein, but it can refold in different shapes, kind of like origami, okay? And we can see there are different forms of them on the left-hand slide for different disorders. So there's PD here, there's chronic, CT is chronic traumatic encephalopathy, and corticobasal is CBD, okay? It folds differently than it does for PSP, okay? So it may turn out that these different folding of the proteins are linked to disease and that we need specific immunotherapies to target the different kinds of proteins and how they're folding, okay? Or maybe we need a bunch of them to target. So this is a new thing, so I wanted to just throw it out there. All right, so I'm gonna stop, I'm over time already, but bottom line, I just wanted to say, not everything that is PD is PD. PSP is one of the most common forms of it, and atypical Parkinson's disorders. There are new clinical criteria to help us physicians identify this, and our goal is to identify this diseases early on so that we can help you early on. The earlier, the better, okay? And there are common pathological hallmarks that are helping us. There are new novel biomarkers coming out. It takes a team approach. Their drugs are not great. We need better studies. And then there are new novel things and things coming on the way. There is hope, okay? So I'm gonna stop right there. Thanks for your attention.